to the Kuros Biosciences Masterclass. My name is Robin Young. I'm the publisher of Orthopedics This Week. Kuros was awarded the 2020 Spine Technology Award by Orthopedics This Week for its fibrin PTH technology, which is the first drug-biologic combination for spine fusion. The Spine Technology Award was designed to recognize the engineers, the scientists, and the inventors who really do the perspiration in addition to the innovation that is essential for excellence in innovation and to create technologies that could potentially be practice changing. So thank you all to our attendees for joining. We really have an outstanding faculty today. Sig Berven, MD, is our first faculty member. He's the professor of orthopedic surgery at the University of California, San Francisco Department of Orthopedic Surgery. Dr. Berven's research interest is in the assessment of outcomes for patients who have orthopedic surgery. He also studies minimally invasive techniques in spine surgery and is exploring cellular and molecular techniques to biologically regenerate components of the spine, including the intervertebral disc. Dr. Berven studied at Stanford University as an undergraduate and at the University of Oxford as a graduate student. His medical degree is from Harvard Medical School. His residency was in the Harvard Combined Orthopedic Residency Program. He advanced his training as a clinical fellow at UCSF and in pediatric orthopedic surgery as chief resident at Boston Children's Hospital. His lectures include the measurement of outcomes in spine surgery, evaluation and management of spine disorders, and advanced techniques in spine surgery. Our other faculty member this evening is Frank Lamarca. He is Director of Complex Spine Surgery, and he's the Medical Director of Neurosurgery at Henry Ford Allegiance Health in Jackson, Michigan. Dr. Lamarca specializes in neurologic surgery, and his particular interest is in complex spine surgery, including spine deformity, scoliosis, and kyphosis, with the application of minimally invasive spine surgery techniques to those pathologies. He was Director of Spine Surgery for the Department of Neurosurgery at the University of Michigan from 2003 to 2017, where he built a nationally acclaimed practice dealing with complex spine surgery pathologies. In addition to authoring over 100 publications, Dr. Lamarca is one of only 2 neurosurgeons to have been awarded the Visiting Fellowship Award from the Scoliosis Research Society. He was founder and director of a CASH-accredited complex spine surgery fellowship program that has trained 12 fellows across the United States, along with many residents from the University of Michigan. I will now pass the program over to Dr. Catherine Sage, a board-certified orthopedic surgeon, a close friend of mine, and the Scientific Affairs Director at Kuros Biosciences, and she'll give a brief description of Kuros as a company. Dr. Sage.
Thank you for having me here today, Robin. It's always great to see you. As Robin said, I'm Catherine Sage. I'm a board-certified orthopedic surgeon, and I'm also the Scientific Affairs Director here at Kuros Biosciences. I'm here today because spine-related pain is taking a huge toll on our society. More bed days, more days off work, and at a greater financial cost to westernized healthcare than any other condition. Kuros Biosciences is on a mission to ease this burden through superior biologics for better spinal fusions. To deliver the ideal bone graft, we believe you need the highest quality and quantity of scientific evidence. And this is why we're hosting this virtual masterclass alongside Orthopedics This Week. Our goals are to help surgeons understand the differences in bone graft categories, understand the scientific data for the various classes of bone grafts, and recognize that choosing an effective bone graft can improve fusion outcomes by up to 60%. Before we begin, I'd like to introduce Success is in the Surface. This is a short product animation video regarding MagnetOs. After the video, we are honored to be joined by Dr. Frank Lamarca from Henry Ford Hospital in Michigan, who will be presenting next. And following that, we'll be joined by Dr. Sig Berven from the University of California in San Francisco. Thank you so much.
Kuros Biosciences have developed MagnetOs granules, a bone graft with the unique submicron surface topography. MagnetOs granules are available in a moldable putty, allowing the surgeon to sculpt the graft accurately to bony defects. Once implanted, the polymeric binder is rapidly resorbed, leaving the granules in place to take effect. MagnetOs granules are designed to mimic the porous trabecular structure of cancellous bone. Unlike first-generation bone grafts with conventional surface architecture, the advanced surface of MagnetOs has needle-shaped features that are submicron in size and ideal for the attachment and spreading of macrophages. When the patient's macrophages are exposed to the submicron surface topography of MagnetOs, they are reliably polarized to the M2 phenotype. Macrophages of the M2 phenotype have been shown to perform several functions in bone. They remove debris from sites of bone repair and restore the extracellular matrix by promoting secretion of collagen by osteoblasts. Cellular signaling results in mesenchymal stem cells being freed from the surrounding tissues and being drawn to the submicron surface of MagnetOs. Here, they attach and differentiate to osteoprogenitor cells. Signaling also results in mesenchymal stem cells being recruited from the infiltrating vascular system. M2 macrophages have been shown to express BMP2 and crosstalk with stem cells via the prostaglandin PGE2 pathway. The recruited progenitor cells in turn differentiate to osteoblasts. These cells then begin the work of laying down collagen that will soon mineralize to form new bone. Unlike conventional osteoconductive bone grafts, for which there is a greater risk of fibrous tissue formation and scarring, bone formation takes place throughout MagnetOs simultaneously, without the need for added cells or growth factors, resulting in a uniform, solid, stable, and reliable fusion that is equivalent to the gold standard of autograft.
Hello, my name is Frank Lamarca. I am a neurosurgeon at Henry Ford Allegiance Hospital, and I am going to talk to you today about the role of biologics in spine surgery. So as we all know, spine surgery is more than just putting in screws. Our number one goal in many cases, besides decompression of the neural canal, is to stabilize the spine and therefore to create a healthy fusion and therefore a bridging of bone through the various segments that we fixate with our instrumentation. And the most common late onset complications we can see is often pseudoarthrosis, along with others such as adjacent segment degeneration, proximal junctional kyphosis, etc. But pseudoarthrosis being one of the major problems and issues that we tend to deal with and try to overcome when we are putting a patient under a fusion operation. Often the formation of fibrous scar tissue, which occurs before any bone bridging can appear, is what stops the fusion from progressing. So it's to avoid the formation of fibrous scar tissue and therefore permit bone bridging that we typically try to typically try to accomplish and therefore avoid a failed fusion. And there are various things we can look at to see how we can accomplish that. And there's been studies looking at training, how that affects overall fusion rates, and truthfully, doesn't really affect it much. We're all pretty much trained well in our various residency programs, be it neurosurgical or orthopedic. And at the end, it doesn't seem that training really improves our outcomes. Now, with the experience and improvement in surgical technique, we can get some incremental gain in the fusion rates. It's been shown to be as high as 6%. But really where we make a difference is in the appropriate choice of the bone graft, making that, choosing an effective bone graft and therefore positioning it in a bed where it can viably hold and create a bridge of bone through the various segments is what will create an incremental improvement in our outcomes. It's been shown to be as much as 60%. That choice of bone graft can affect the overall outcome in terms of a fusion rate. So the science matters when we're looking at grafts and choosing them. And before I get into that, let's just kind of do a quick overview of the basic tenets of bone healing. And this is pretty basic stuff for most of our orthopedic colleagues, maybe less so for my neurosurgical colleagues, but yet very important given that we do a lot of spine surgery. There are three basic tenets of the triad: that of osteoconductivity. There is the growth factors that are present and necessary in order to induce bone healing. And the migration of osteocytes that then permit for bone healing. You have to have living cells, obviously, the osteoblast, osteoclast, or the ability to achieve migration of those cells into the fusion bed, and therefore there's an osteogenic component. Then obviously there's also an osteoconductive component. These cells have to find a scaffold or be able to create a scaffold upon which they can deposit the calcium phosphates, which then go on, and the matrices that then go on to form a solid bone, a solid healed bone. So as I mentioned earlier, we have the osteoconductive phase, osteoinductive tenet, and the osteogenic component. But there's a fourth, which is relatively new and becoming more and more important in understanding the processes involved in bone healing. That's of the osteostimulative environments. These usually involve materials that create a favorable bone growth environment by increasing osteoblast activity and decreasing osteoclast activity. They can be induced in bioactive manners, having an effect on the living organism or tissues, be that with drugs or other changes in the environment in which the fusion bed is. And these terms don't really fall into the typical traditional classifications of osteoinductive category, because there are no growth factors that are being provided, but rather an environment that increases the formation of growth factors, and therefore all those other elements in bone healing, which we're going to talk about here in a second. Because of the growing understanding of these various types of substitutes and bone growth enhancers, there's been a trend in the type of products we see out on the market over the last several decades. Obviously, initially, besides autograft, there were use of hydroxyapatites that were used in the 1970s. Biphasic calcium phosphates have also been used. In the early 2000s, we had the introduction of growth factors themselves and other the introduction of other types of products such as bioglass, which can induce, to a certain sense, a higher production of BMPs by the local cells. And there's become an increasing interest in nanostructures and submicron structure surfaces and how those interact with cells, and to create a better environment and therefore promote bone healing. Getting back to the details, as I mentioned earlier, we have when we're putting in or choosing a bone substitute or any type of graft, we want to keep in mind their osteoconductivity, and therefore, we're looking at a scaffold. It has to be a scaffold that allows for live bone to grow across the area that we're looking to bridge, or that gap that we're looking to bridge. Typically, osteoblasts will grow from the margin of the defect and utilize the bone graft material as a framework, and then spread along that graft itself, or that scaffold, allowing the migration of other osteoblasts. And then after that, there'll be a reorganization of the graft itself, and in the final product will be a healthy bone bridge. The material and surface topography have been shown to influence cell behavior on that scaffold, and therefore there's a much more and more attention being given to the surface technologies and how the nanostructures interact with these cells. And therefore, it's very clear that surface matters. Surface topology has been found to affect not only the osteoconductivity, but also indirectly osteoinductivity through osteostimulation. And there are various studies, more and more coming out, showing how these nano structures or nano surfaces interact with cells at a molecular level. So there's a certain hierarchy of of communication between a graft or a scaffold and the bone at a cellular level. We have a macro level, around 10 to the minus 3 microns. And then when you start getting to 10 to the minus 6, you're at a micro level. And at the nano level, you're talking almost at a molecular level with the cells. And it's at that level that we really see a change or the ability to stimulate bone formation. An osteostimulative environment typically will upregulate osteoblasts, and that is through the creation or the production from these cells that interact with the surface of TGFs, Bs, BMPs, typical bone morphogenic proteins. There'll be a downregulation of osteoclasts through the TGF-B1s as well. And then an upregulation of angiogenesis, because for healthy bone, you need vascularization and nutrition or some means of creating a viable bone over time. Now, the osteoinductive portion of any bone healing is dependent upon growth factors. These are typically secreted by cells and platelets, particularly mesenchymal stem cells, osteoblasts, inflammatory cells, even fibroblasts will all secrete, and platelets as well, growth factors at the area of an initial injury or of a surgery. These growth factors are also contained in the external cellular matrix and are embedded within the collagen matrix of bone. And that's why BMPs, to a certain extent, may have a certain degree of bone growth factors embedded within them. They do initiate the bone healing cascade, and it's mediated by the release of these cytokines and growth factors over time. And here's just a quick list of many of the growth factors that have an effect on the human skeleton. This little breakdown at a cellular level on how the growth factors play a role in this process. So you'll have an initial injury or surgery where there is a formation of a fracture, either surgically done or otherwise. And in that place, there'll be the formation of a clot. Within that clot, we have platelets, chondrocytes, and macrophages, which are inflammatory cells and that are the first to respond to the injury. And they produce PDGFs and other growth factors that then stimulate the endothelial cells to increase in proliferation, migrate, and permit for vascular permeability, which will then allow for a healthy and live bone at the end of the healing process. But at a cellular level, when it comes to how they affect osteoblasts, the TGF-Bs or betas and the BMPs tend to stimulate not only the cells to migrate and proliferate and produce extracellular matrix, which is the fundament for bone healing, but also at a nuclear level, it will create gene activation and activate these cells along multiple pathways, which creates then the formation or the secretion of more growth factors and a cascade which eventually results in the formation of bone. Obviously, at the same time, though, you're having the creation of fibrous scar, which is counterproductive when it comes to bone healing. So to regulate this process more towards the bone formation phase instead of a fibrous phase, one can go down various routes. Now, one of the most common used since the early 2000s and logical would be, why don't we just introduce bone morphogenic proteins? And recombinant proteins obviously have been on the market. They are used at a supraphysiological dose, and therefore it's a single growth factor and is placed at massive doses, which are not commonly seen with normal bone healing. Other growth factors can be present in DBMs, but at a more physiologic level, but not always are they available for the cells to access, and therefore don't have the power that a big BMP dose would have. But there are some side effects or cons to the use of these supraphysiologic doses, and complications have been reported more and more with the use of bone morphogenic proteins. We all know of the possibility of ectopic bone formation, These large doses can cause a significant inflammatory response with the formation of seromas, which can then cause compression and even been reported to present with life-threatening type complications. The inflammatory response also can result in osteolysis, so a negative effect compared to what we want to create with the bone morphogenic proteins themselves. This study that we did years ago, and we were able to, and it is very concordant with other studies in the literature, where there's approximately an 11% incidence of osteolysis with the use of bone morphogenic proteins. And this can also result in the collapse, and you can see these osteolytic changes in these particular cases. It can also cause the collapse of allograft structural implants, and therefore you lose, with the disintegration of those structural implants, you lose the stabilizing effect that one wanted to create when they were first implanted. There are also systemic complications that have been reported, such as retrograde ejaculation, especially in the use and when done with ALIFs. And there's always a back of the mind risk of increased cancer risk, and many reports of delayed or late onset radiculopathy that is very difficult to treat. Because of that, we tended to get away from the BMPs in many cases to try to avoid those complications when possible. The introduction of osteogenic cells have also been another option that's come out on the market. The problem, though, with these cells is many, and I'll let Dr. Bervin talk about those to follow. But one, are they viable? Do they really create bone? And do these stem cell products actually differentiate in the direction you want them to? Because histocytic stem cells can differentiate in a osteoclast direction, while mesenchymal stem cells tend to go into the osteoblast direction, both of which tend to be directionalized or activated, let's say, by the inflammatory process itself. So when that works, that's fantastic. But like I said, the cells are questionable in their efficacy, and there's not a whole lot of data out there. But again, I'll let Dr. Bervin talk to that more to its effect. But as I mentioned, these cells are all activated via the inflammatory response. So there's an immunologic component that initiates the entire process, and getting that process underway in the right direction early on definitely give a better chance of osteoblast formation or osteoblast activation, which then turns into more healthy bone formation. Here's another scheme showing the cascade, signaling cascade in bone healing. You've got that initial injury, clot formation with the presence of platelets, which secrete TGF-betas and PDGFs. There's a subsequent inflammatory reaction with migration of macrophages and other inflammatory cells that secrete further growth hormones or growth factors. And then that brings on a migration of more osteoprogenitor cells, further enhances the secretion of these growth factors, on and on until you have the formation of an initial periosteum-derived healing callus, which then reorganizes with the introduction or the activation of osteophytes and the introduction of vascular ingrowth into a healthy mature bone. But it's at this level with the activation of macrophages that it all kind of really gets going, and where a product like Magnetos has its effect. When you look at macrophages, they tend to once they're activated, to polarize. You'll have an M1 type macrophage, which often induces a pro-inflammatory type response and a fibroblast proliferation. And that macrophage is the one that actually leads the healing process more towards the formation of a fibrous scar tissue. The M2 macrophage, on the other hand, upregulates the mesenchymal stem cells towards osteoblasts with the release of growth factors that stimulate osteoblasts themselves, and therefore it polarizes more toward, or it activates the healing process more towards that of bone healing. So whenever we look at an implant or a graft substitute, we typically want one that's going to activate the M2 phenotype more so than the M1, because we don't want that graft to turn into a big glob of fibrous scar, but more so into an organized bridge of bone. Now, how does this stimulation occur at a cellular level? Typically, when we look at osteostimulative implants, we refer to biologics that fall outside of that healing triad, as I mentioned earlier, and they stimulate and promote bone growth. And many of these minerals that are present on on our implants or on our bone graft substitutes act as osteostimulative minerals in the way they interact, obviously, with the cells. Calcium phosphate being one, apatite, ceramics, bioglasses. These are all options that are out in the market. You tend to want to increase the stimulation, not of osteoclasts, but which cause resorption and remodeling, but more so of the osteoblasts, and that graft also should have a certain degree of porosity, which allows for migration of the osteoblasts into its space. Magnetos is a biphasic calcium phosphate. It mimics the porous and trabecular structure of cancellous bone, and it tends to polarize macrophages towards the M2 phenotype. And the way it does that is it harnesses the M2 macrophages' ability to deliver growth factors that then transform the whole down cascade type reaction into uniform and reliable bone formation. The submicron structure of magnetos has this needle-shaped type features which interact with the macrophages and have been shown to favor spread and augment that bone formation, even in soft tissue, which is what is most impressive of the science behind this product. It comes in granules that are binded by a polymer. The polymer tends to absorb quite quickly, leaving the granules behind. These granules allow for the macrophages to migrate within the structure itself, therefore creating a formation of bone almost from the inside out as well as from the outside in. This is an electron microscopy picture showing how that needle formation on the left of the magnetos surface tends to polarize the macrophages towards the M2 phenotype. And you see that the star-shaped or spinous type shaped macrophages in that picture are typical of the M2 macrophage, while the more spherical ones on the right, and this is, I believe, a VTOS bone graft, are typical of what you would see of the M1 phenotype, which, as mentioned earlier, activates more towards a fibrous scar formation. Mesenchymal stem cells and osteogenic precursor cells are directly and indirectly induced to differentiate, as I mentioned, into osteoblasts, thanks to the intervention of these macrophages that secrete the growth factors that induce those cells to do so. It's a schematic picture kind of showing how not only do the macrophages help induce osteoblast activation, but can also induce the endothelial activation necessary for healthy bone and therefore vascularization, angiogenesis within the graft itself. And that is done through the same pathways. And as I mentioned earlier, because of that, it creates bone growth from the core as well as creeping in from the edge, therefore create a much more healthy substrate of bone throughout the entire graft itself, and not just a shell of bone on the outside of the implant. So in summary, there are a multitude of biologic options available in the market for spine surgery. Not all of them work in the same way, and one needs to understand that. And to do so, you certainly need to understand the science to a certain degree. It's very interesting how osteoimmunology has a very important effect in the entire cascade of bone formation and at the very beginning of it, and therefore initiating that cascade in the right direction. And magnetos has the unique property that it is able to grow bone thanks to its ability to harness this osteoimmunological aspect of bone growth, even within soft tissue. It's an affordable graft and allows for new bone formation, I mentioned, that is biomechanics equivalent to autograft. And it's something that we're looking at more and more in order to hopefully create a more physiologic bone healing process, which will help avoid some of those complications and negative effects we mentioned earlier.
Yeah, so the first polling question we've got is a single choice answer. So what really drives your decision making about bone graft materials? And there's 6 choices. Is it primarily the price, the outcomes data that's available, whether or not it's available in your system or your formulary? You use what you're trained on. You evaluate value in biologics, meaning some balance of performance and price. And then the final is the risk and complication profile. So which of these actually drive your decision making? We'll give people a moment to vote. And
which commercial bone graft material have the best evidence to support them?
And here you can choose multiple choices, but we'll need to put up the polling questions so that people can actually answer it, or you can scroll down. And that's already been answered. So the answers here for which commercial bone graft materials have the best evidence to support them. The DBMs, about half the people thought the DBMs have a high level of evidence. Certainly the growth factors and BMPs are next. Peptides, P15, and some of the synthetics are tied for third. And then the cell-based matrices trail on that polling question. And then finally, which commercial bone graft materials require more evidence to support their usage? So which materials do you think we need more evidence for? And certainly the majority of people thought that sort of cell-based allograft and cell-based matrices really need more information to support them. Next would be the peptides, so P15 being an example there. Synthetics need more information. And perhaps the DBMs and the growth factors, I think what I read into this is that maybe the best evidence exists right now for the growth factors and DBMs, and those have been the most widely studied according to the poll. So with that, I'm going to close the poll, and I'm going to give a bit of an introduction to bone grafts. So Frank just did a terrific job of talking about some of the basic science of bone graft materials. And my role is going to be a little bit different. My name is Sigurd Bervin, I'm Chief of the Spine Service here at UCSF. And we use a lot of bone grafts at UCSF, and there's a lot of variability in what we choose to use. And I'm going to present really an overview of some of the things that we might choose to use. And I'm really going to try and make this primarily a teaching overview, showing some evidence for each of the categories, and really trying to not emphasize any one versus another, but the spectrum of materials that we might use. So with regard to that, when we think about osteobiologics, what we're really trying to do with our osteobiologics is mimic the functions of bone. And bone fundamentally has 2 phases. There's an inorganic phase, or the mineral phase of bone. In the mineral phase of bone, we recognize as calcium hydroxyapatite. And certainly some of our ceramics and synthetics, the purpose of those is to mimic the mineral phase of bone. The mineral phase of bone is really what's got the standard micron sizes that and porosity that Frank alluded to. And it's the mineral phase of bone that really gives us osteoconductive properties. Bone's also got an organic phase. And by demineralizing bone, this is what exposes the organic phase of bone. And certainly type 1 collagen is the most common protein in bone. The organic phase also contains cells. And importantly, the organic phase contains some non-collagenous proteins, including, perhaps most importantly, BMP, which is what Marshall Urist identified as being the osteoinductive component of bone. So recognizing the organic phase and the inorganic phase in our mineralized matrices have both a mixture of organic and inorganic, and our demineralized bone is really focused on trying to yield the organic portion of bone, and particularly the BMPs, which are osteoinductive. So we recognize that there's a lot of variability in how we approach common spinal disorders. And I often say that the presence of variability is clear evidence of the absence of an evidence-based approach. And information on certainly clinical outcomes, I think, is fundamental to some decision-making, informed decision-making. And the majority of people wanted to know information on outcomes and cost, and the combination of outcomes and cost to understand the value of their decisions or the value of the products that they're choosing between. And again, there's a lot of heterogeneity in how we apply our bone graft materials. It depends a lot on the patient's diagnosis. We might use different material for a child than an adult. We might use different material for a patient with tumor than a patient with degenerative pathology or infection. The surgical approach, certainly anterior approaches versus posterior approaches, the comorbidities of the patient, whether or not they may have bone marrow or autogenous bone that may be useful. The cost we alluded to already is certainly an important consideration and largely drives what makes it to our formulary in the first place. And of course, the complication profile and understanding the possibility of disease transmission, understanding the possibility of some of the complications that Frank alluded to, including heterotopic bone formation, osteolysis, and other potential complications. So understanding this is really what drives our decision-making. And there's been a terrific evolution, certainly in the past 20 years, of what we're doing with our bone graft materials. We've got categories including bone graft materials that are primarily osteoconductive, bone graft materials that are primarily osteogenic, osteoinductive, and with mixtures of each of those functions. And a lot of times the evidence that we're using to guide our decision-making is really based on preclinical data. And I think that can be incredibly valuable. In fact, most of the time when we're doing head-to-head comparisons, it's going to be on a preclinical basis. It's really important, I think, to understand both the efficacy of bone graft materials as well as the complication profile in order to make an informed choice for our patients. I often talk about different levels of proof, and certainly, ideally, we'd have proof beyond a reasonable doubt. Proof beyond a reasonable doubt would involve a randomized prospective clinical trial, and some of the materials we're choosing between have done a nice job with looking at level 1 evidence and randomized prospective clinical trials, specifically some of the work that's been done with BMP as well as P15. I think very nice comparative studies there and level 1 evidence. And in other studies, we're really dealing with more or on other materials, we're dealing with more of the preponderance of evidence. So we're looking at preclinical studies, we're looking at some prospective cohort studies, perhaps case series, retrospective studies with comparisons to literature. And what's oftentimes missing is a direct head-to-head comparison, at least in our clinical studies. And that's what makes it difficult sometimes to really have a firm understanding of what the clinical efficacy of these materials are. So I think comparative studies are useful, and we need more of those. And I think preclinical comparative studies certainly can be useful. That's where we might see some of the more subtle effect sizes and some of the effects of mineralization, some of the effects of actual looking at histology can be very valuable. And I think clinical studies, while less likely to show differences, and I'll share that with you, certainly in our randomized clinical trials, really very little evidence to show superiority of one material over another. Our clinical studies ultimately are what we're accountable for. So both are important. And again, this is just a diagram showing that sometimes we've got compelling evidence, we're hit over the head with a club, and more often we're weighing a balance in a range of supportive evidence. Again, looking at preclinical studies as well as imperfect clinical studies. So looking at some of the options specifically focused on posterior lateral fusion, we often think about iliac crest bone graft as being the ideal material, or perhaps the material that we use as a standard. Bone graft from the iliac crest is certainly osteogenic. You've got your marrow cells. This can be osteoinductive and also, importantly, osteoconductive because there's a mineralized matrix there. There are some limitations, of course, of the iliac crest bone graft, including the fact that there's a limited supply. And certainly we recognize some of the morbidity of harvesting bone graft. Some of the synthetics that have been used commonly can be osteoconductive and in some cases actually bioactive. They can actually stimulate osteoblasts. The DBMs we've spoken to, the DBMs are demineralized bone, which essentially isolate the osteoid component of bone. So unlike synthetics, where we're isolating the synthetic phase of bone, or I'm sorry, the inorganic phase of bone, the DBMs are isolating the organic phase of bone, or the proteins. And now with some of the cell-based DBMs, indeed, the possibility of actually having some viable cells in addition to the proteins. And then finally, the growth factors or recombinant proteins, most notably in spine, certainly BMP2, can be really highly effective but we've got to recognize some of the price constraints as well as some of the limitations of where the BMPs might be effective. When we're thinking about any type of new technology, be it a bone graft material or a new device in medicine, I think that this graph on the right is quite useful. If you think about the middle kind of being the index where we're starting from, is we're willing to pay some incremental cost for something that's more effective. And in general, we're dealing with that upper right-hand quadrant here when we're thinking about cost effectiveness of what are we willing to spend to improve health status outcomes. Certainly that's our ultimate goal. To improve the durability of the outcome, to avoid some of the late failures that Frank talked about with pseudoarthrosis, to avoid complications, including non-union or screw loosening, to look at safety and value. And ultimately, that's what we're really trying to get with our bone graft materials and make an informed choice about bone graft materials. In broad categories, when we think about types of bone graft, we've got bone graft that are either human-derived or synthetic. And certainly our allergenic bone, as well as our autogenous bone, are human-derived, allergenic obviously being from a different human. And then we've got our synthetics and our peptides, as well as our recombinant proteins, which are not actually human-derived. And to that end, certainly autograft has got some terrific value. And I think that in general, when available, this is our go-to, be it either local bone or in many cases bone from the iliac crest or bone from rib or other sites. And autograft has got some terrific benefit in that there's a lack of immune response. The cost can be cost effective, although there is some time to harvesting autograft. And again, the limitations are the limited supply as well as morbidity from the donor site. Looking at alternatives to autograft, the poll suggested that one of the areas that's got a lot of evidence is demineralized bone. And I'd like to just speak a bit about demineralized bone and recognize the work of Marshall Urist, who back in 1965 wrote about the formation of bone by autoinduction and using a submuscular pouch, took the organic phase of bone or the demineralized bone, the osteoid, and actually separated osteoid, separated the proteins in a gel electrophoresis and implanted different proteins of different sizes and identified the bone morphogenetic proteins as proteins in a range of about 1,200 kilodaltons that consistently form bone in a submuscular pouch. And the demineralized bones, I think, have some real benefits. I think there's good evidence to suggest that demineralized bone matrix has been effective. I think the deactivation has provided some safety for the DBMs, and they can be affordable, available in many different formulations, including mineralized and demineralized matrices together, and a long history of clinical use with good data to support the clinical use. And I'll share with you some of that data. One of the troubles with some of the DBMs is that there's a lot of variability in the osteoinductivity by product. And this has been written about by several authors. Rick Delamarter, the group down at UCLA, Jeff Wong, looked at this and suggested there's a lot variability. We actually measure how much BMP2 and BMP7 is in the different DBMs, more than a 5-fold variation. And the rates of fusion also vary quite dramatically. Or in this instance, looking at the ability to form heterotopic bone nodules or fusion rates up to about 75% in some of the animal studies, but in some cases, no fusion at all. And this just shows graphically the variability of what we're seeing with regard to BMP content in some of the different commercial preparations, as well as fusion rates. Some of the fusion rates that were really quite high in the range of 75% in animal studies, and some of the different DBMs offering no fusion at all. So I think when we're thinking about our DBMs, make sure we understand what the osteoinductivity is of the specific DBMs that we choose, and be well informed that there is some variation, and different DBMs may have different levels of evidence to support them. This is a nice study that Jim Kang did when he was in Pittsburgh. It was a multi-center prospective randomized trial looking at 41 patients overall, 2-to-1 ratio of patients getting DBM versus iliac crest bone graft. And interestingly, what they showed was very similar fusion rates between the patients fused with iliac crest bone graft as well as DBM. And overall, the iliac crest bone graft group did have some more blood loss. And looking at the patients who were treated with local bone with graft-on matrix as a extender, the fusion rate was about 86% on a CT-based criteria, and a similar rate to what we saw in patients with iliac crest bone graft. So suggesting that DBM can be very useful and effective as a local bone extender. What about cell-based DBMs? And I think that the evidence for cell-based DBMs we'll see is really quite a bit less supportive. And specifically, the idea of cell-based DBMs is the possibility of actually maintaining mesenchymal stem cells or pre-osteoblasts that may be active in contributing to the regenerate. Having said that, I'll show some evidence that suggests that the evidence for this is actually really incomplete and somewhat poor. Zora Buser was a PhD, or is a PhD from USC now, and she did her training in our lab at UCSF, and she did some terrific work looking at cell-based DBMs versus DBM only. And what she found here is that the cell-based particulate DBM, really the viable cells versus devitalized cells had no difference at all, and in no instances was there any fusion with the cell-based DBMs. Now, having said that, when the cell-based DBMs were mixed with a fiber-based DBM, meaning that there are actual fibrils of DBM with the cells, that was certainly more effective in the fusion rate, but still the fusion rate of the cell-based DBMs was significantly worse than the non-cell-based DBMs. So it certainly brings into question whether or not the cells are offering much in the way of efficacy. And this has actually been studied by others. The conclusion of Dr. Buser's study was that the cellular component of the commercially available cell-based DBMs really did not add significant additional benefit in terms of fusion rate. Here's some work that Corey Chan. Corey was a fellow with us, as a clinical fellow in neurosurgery at UCSF and terrific researcher. And Corey looked at single-level ACDFs. And similarly, his conclusion looking at single-level ACDFs and pseudoarthrosis with cell-based DBMs was poor compared to the literature. And then finally, this study done by Jeff Wong and Pat Shea through the AO Foundation, they concluded that looking at a systematic review, the overall quality of evidence for some of the cell-based DBMs and allogeneic cells for both lumbar and cervical fusion is quite poor. So I think certainly as the panel poll question suggested, we need more evidence to support the use of cell-based DBMs. And right now, the evidence that we've got available would suggest that cell-based DBMs perhaps underperform DBMs without cells. And of course, one of the major concerns we have with regard to any type of human tissue is disease transmission. And I think most of you are familiar with the 7 patients who actually tested positive for tuberculosis, or 4 patients tested positive for tuberculosis. 7 had a post-surgical infection with the use of one of the cell-based DBM products. So overall, the evidence for cell-based DBMs has been poor. And as the panel suggested, perhaps more work needs to be done in that category before that's used with much enthusiasm in our patients. What about the peptides? And I think the peptides, this is a category of bone grafts that really use cell signaling through peptides that may be involved in bone formation, bone pathway formation. And P15 is a peptide I think has been very nicely studied. And indeed, there is some level 1 evidence to suggest efficacy compared to local bone. And I'll share that. So specifically, in a prospective randomized study of patients fused with allograft and P15 compared to allograft with local bone alone, the fusion rate was quite equivalent. There were some outcomes that were slightly improved with P15 compared to local bone. But having said that, substantially equivalent with regard to fusion rate in the cervical spine, and actually somewhat better in a non-discriminative posterior lateral fusion with patients treated with P15 as a bone graft extender compared to allograft alone. Some concern about some post-operative CT scanning that might have shown some graft migration. And again, looking at the complication profile is also important when we're thinking about our bone graft materials. And then finally, BMPs, and this is where I think we've got some of our most rigorous data with regard to randomized prospective studies. The BMPs, of course, are our osteoinductive growth factors that Marshall Urich identified as the osteoinductive components of bone. And isolating BMPs using recombinant technology gives us a terrific ability to apply a high concentration of protein to our surgical site. So certainly great efficacy with regard to bone formation. And I think some of the best data looking at BMPs has been in randomized prospective trials. What we know is that fusion rates are really quite high, both in the interbody space, as well as in some studies where BMP has been used posterolaterally. And the YODA studies, I think, really give a best summary if you're looking to have some evidence to look at overall at the efficacy of BMPs. And comparing autograft to BMP, overall substantially similar with regard to most of the outcomes, slightly higher back and leg pain in patients with BMP compared to autograft, but otherwise very similar efficacy as well as complications. So really similar fusion rates, similar overall success randomizing patients to BMP versus autograft. And this was really over 13 randomized clinical trials and 31 prospective cohort studies is what the YODA study put together here, or the YODA cohort put together. Very similar adverse event profile, and not much to suggest a benefit, but similar efficacy to autograft. What about the synthetic bone grafts? And again, the idea of synthetic bone grafts is that we can actually mimic the mineral phase of bone. So recognizing that bone has an organic phase and an inorganic phase. The organic phase is where the proteins are. And we talked about BMP being one of the important proteins in the organic phase, and DBM trying to isolate and harness the power of that organic phase. And the synthetics are really mimicking the inorganic phase of bone. And with the synthetics, we've got the ability to really quite precisely create a mineral that is very similar to our own calcium hydroxyapatite, and in some cases perhaps even have more bioactivity than calcium hydroxyapatite. So synthetics have certainly been around for a long time, and recognizing some of the early synthetics, calcium sulfate, which has properties where it resorbs very quickly, and some of the other hydroxyapatite, beta CTP, and bicalcium phosphates have been very effective at mimicking the mineral phase of bone, and generally as osteoconductive matrices and bone graft extenders. The next generation of synthetics, I think, involve the bioglass and siliconated products, and some evidence for efficacy and increased bioactivation. Some evidence in preclinical studies suggests that activation of osteoblasts and extracellular matrix production can be actually stimulated by the bioglass synthetics. And then now with some of the more advanced surfaces, increasing the surface area, as well as some of the morphologic features of the surface that may actually induce some of the cells involved in the inflammatory phase of bone healing, including macrophages, to actually produce regenerative proteins, including BMP. And that's really what we're dealing with now, is this so-called newest generation of synthetics. Again, some of the early synthetics, calcium sulfate, hydroxyapatite, GCPs, bicalcium phosphates, these can be quite cost effective. A lot of variability in resorption properties, and that's certainly something we want to pay attention to. You know, sometimes we might actually mix antibiotic with our calcium sulfate with the intention of that reabsorbing. Sometimes a longer reabsorption time can be useful. So, for example, our hydroxyapatite tends to resorb over a much slower profile. But generally, we want to have a synthetic that mimics or that matches the rate of resorption with the rate of new bone formation. Adding siliconated products in bioglass really can be quite useful, and some evidence, again, that this might add some efficacy with regard to osteostimulatory properties and the ability to stimulate osteoblasts to produce more extracellular matrix. And some of the siliconated calcium phosphate products that were introduced in the early 2000s. Again, what's happened here is the substitution of silicate ions for some of the phosphate ions, and some evidence that this might actually improve some of the osteostimulatory properties of the materials. And bioglass is an example of that. And some of the more advanced synthetics, really, Dr. Lamarck has already covered this, but the idea that some of the surface topography can be harnessed to actually stimulate some of the cells that are involved in the inflammatory phase of bone healing to actually produce extracellular matrix, and in some cases to produce regenerative proteins, including BMP. And with some more advanced synthetic manipulation, we can actually resorption profiles, so our resorption rate matches our new bone healing rate. And we can also manipulate the handling properties as well. That can be very useful for some specific applications. Some of the evidence to suggest that that synthetics can be quite useful. This is a paper that was from Bill Walsh in the Clinical Spine Surgery Journal this year. Suggests that the efficacy of calcium phosphate micron topography can really be quite useful, and that overall the bicalcium phosphate that's characteristic of the Magnetos product actually performed equivalently to autograft in this preclinical study. So overall, I think that synthetics, there's good evidence to suggest that these can be safe and really quite effective. The preclinical studies are very promising, suggesting perhaps efficacy to autograft. And I think that we certainly need more evidence and clinical evidence to make a complete assessment and informed decision about our newest synthetics. So I'm going to wrap this up by suggesting that we want to apply the right technology to the appropriate clinical needs. And when we think about clinical needs, we want to think about our host. What's the age of our host? What type of previous surgery have they had? Where are we operating? Are we operating in the inner space where we've got perhaps a bigger surface area and the ability to have marrow come from the end plate? What are the patient's comorbidities? What's the difference between fusing something in tension versus in compression? Some of the surgical factors. How long is the fusion going to be? That's got a big impact on how much bone graft we might use. And in many instances, cost becomes very relevant there. Is this a revision surgery versus a primary surgery? What's the likelihood of this healing? What's the likelihood of a non-union? And again, the interbody space in compression versus the posterolateral space or fusion area and tension can have a very different clinical need. So sometimes I say, I live out here in California. We've got a lot of redwood trees. You don't want to try and necessarily cut down a redwood tree with a handsaw, meaning sometimes we don't want to certainly underpower our bone graft materials. And at the same time, over Thanksgiving coming up, we don't necessarily need a chainsaw to cut turkey. So trying to match our needs to our equipment is important. And we don't always necessarily need the most potent osteobiologics. And sometimes that might actually be inappropriate when we think about cost and complication profiles. And to that end, I think that this might be a useful algorithm I published some time ago now, looking at both the host properties or the bone healing potential. So somebody's got very good bone healing potential on the bottom versus poor bone healing potential. And then what's the size of the area that we're trying to fuse? So for example, somebody with good bone healing potential and a small space like an ACDF, that's a much less stringent environment than somebody where we're doing a revision adult deformity for somebody who's already got a pseudoarthrosis, whereas very poor bone healing potential and a very large defect. And to that end, what I would suggest is oftentimes our osteoconductive matrices can be used for our low-risk environments. Osteoconductive matrices, as well as something osteogenic, I think can be quite useful for our intermediate healing environments. And I tend to save our osteoinductive materials, including BMPs, for the higher risk environments. So I just put this up here as an example, just to really make this tangible. These are some cases of mine. 2-level ACDF. In my hands, I tend to use an allograft with a synthetic inside the allograft, just with my preference in general. The second case along the top is a TLIF. My preference for TLIF has to do with handling properties. So I'll typically, again, use the synthetic in the interbody space with local bone, and then local bone with either synthetic or DBM in the posterolateral space for a TLIF. For standard ALIF, and that's on the far right, I tend to use PEEK and BMP for my ALIFs. For a long deformity, now we're getting into costs. And I have a lot of local bone in the long deformities. And quite honestly, I tend to use an allograft because of the absolute volume involved in a 12 to 15 level case or longer. And then for tumors, I think tumors are a major challenge. And I think tumors certainly where I can take local bone that's not involved with tumors. So for example, oftentimes taking rib from a posterior VCR or sometimes taking bone that's not involved with tumor locally, I'll use that. And I'll tend to augment that with a mixture of things. And sometimes that'll involve synthetic, or even on rare occasion may actually involve BMP. But those are a profile of some of the things some of the choices that I tend to make. As a conclusion, I'm going to suggest that there's a lot of variability in how we choose our bone graft materials. It's awfully important to really know the evidence that supports or perhaps refutes each of these. I think decision-making is often made with incomplete data. So oftentimes we're making decisions based on cohort studies or oftentimes based on even preclinical studies. I think matching our bone graft choices with patient needs can provide a framework for informed choice. We certainly don't need the most potent osteobiologics in every instance, but there are instances where that can provide cost-effective care. I think some of the synthetics I'm encouraged by, and a big reason why that market is growing is that these are safe and really quite effective options for a good number of cases. And some of the advanced synthetics have the ability to actually harness some of the immunobiology and improving the regenerative capacity of the synthetics compared to some of the prior formulations. I think we need to remain really quite vigilant in our assessment of evidence and really continue to consider incremental cost effectiveness as we're making informed decisions about our choice of bone graft materials and try and come up with cost effective solutions that are really value based, that really take into account both clinical efficacy as well as cost. So these are just some of the references for some of the slides I put up there. And I think what we're going to do now is transition to a couple more polling questions, and hopefully we'll have some interaction and discussion. But Bonnie, if you put up these last polling questions, and just as an instruction for those of you who are answering these, you can just go ahead and scroll down and do all three. So the first question I'll read aloud. And if you were to rank these bone graft materials you find most useful for posterolateral fusion, so posterolateral lumbar fusion, which of these would you find most useful? And you can rank more than one. So autograft, cell-based matrices or cell-based allografts, non-cell-based DBM, growth factors like BMP, peptides like P15 are some of the synthetic matrices. So which would you tend to use for a posterolateral fusion? The next question is, which bone graft materials are you most likely to use for a TLIF? So if you were going to do a TLIF, what materials are you most likely to use? And again, you can choose multiple choices. You have autograft, your cell-based allografts, DBMs without cells, growth factors for TLIF, peptides, or synthetics. And then the third scenario that we're choosing here is which material would you most likely to use in an ALIF? And again, who's taking autograft for an ALIF, who's using a cell-based DBM, DBMs without cells, growth factors, BMP2, peptides, or synthetics. So again, those are our three polling questions, and we put those up there with the intention of getting an idea of what the spectrum is of utilization amongst those of you who are practicing as surgeons. So looking at posterolateral fusion, I think the vast majority of people are certainly using some local bone and autograft, and that may also include potentially iliac crest bone. Cell-based matrices, those are used in about 20% of the respondents. DBMs have the highest response, and growth factors, including BMP, about 25% of people. Peptides, just one person using peptides posterolaterally now. And then synthetics were third after autograft and DBM with regard to the use of synthetics posterolaterally. Well, what about an TLIF? And in a TLIF, again, autograft, be it local bone or combining that perhaps with iliac crest bone, is the most common, although BMP also matches that. So autograft and BMP in the TLIF. Cell-based matrices are less common. So cell-based matrices and synthetics are less common. DBMs are second after BMP and autograft. And then finally, the least common here are the peptides with TLIF. And then finally, which bone graft material are you most likely to use in ALIF? And clearly the BMP, I think, is the majority of the respondents are using BMP. Certainly some people are using synthetics in their ALIFs, DBMs, and then the lowest response for the cell-based DBMs and the peptides. So it's an interesting overview, and I think is a good reflection of what's being used now. And I think over the course of time, that's going to evolve with the development of more information and with more studies and perhaps further studies to give us more compelling information. Because right now, I think this degree of variability is somewhat a reflection of the fact that there's no one product for every situation that's necessarily got compelling information. So let's go ahead and I'm going to invite Robin to maybe direct some of the questions. We've got the question and answer section available for those participants, and please enter any questions into the question and answer section. Frank, can I address that one? Why don't you go ahead and share your thoughts on BioGlass and address it?
I mean, the data kind of shows that the BioGlasses and to a certain extent in the hydroxyapatite can interact with cells at a nano level to a certain extent and activate osteoblasts, particularly in secreting growth factors. There's a lot of compelling evidence to that effect. Now, hydroxyapatite's been around a long time, and it kind of mimics the inorganic phase of bone, and as Sig had mentioned, and is a very good substrate for bone conductivity or osteoblast conductivity, as well as incorporation into bone, because it has a absorption phase that is similar, and then allows osteoclasts to remodel and adhere new bone to the surface. So yeah, there are different synthetic or mineral composite that is very important, and it shows some positive data. I don't have much experience personally in BioGlass. Hydroxyapatite, on the other hand, I've used on coated implants, and it seems to help osteointegration between the implant and the bone itself. So this is my opinion on that. If you want to add something to that.
Terrific. Dr. Sage, do you have any questions to share?
Sure, I'd love to. Thanks, Robin. Thanks for being here, Dr. Berman, Dr. LaMarca. So where is the sweet spot in terms of preclinical evidence, clinical evidence, in terms of quality, in terms of quantity, for both of you to support the use of a bone graft that's on the market right now, whether it's a full category or a specific bone graft, kind of by name? What do you look for?
Yeah, Catherine, maybe I'll start on that. And I think in terms of a sweet spot, it really depends a lot on the specific application and on the patient. So both the orthotopic site of where we want bone to form, as well as the clinical scenario. So to that end, I think for the patient where there's a really high demand need, a patient with a pseudoarthrosis, a patient with prior radiation, for example, a patient who's at a high risk for non-union, I'm going to really try and use all I can. In general, in my hands, this can involve a circumferential fusion. And oftentimes in my hands, I'm using BMP in the front in those instances. And with regard to posteriorly, I'll try and take a lot of local bone. I'm doing a lot of osteotomies in some of these complex cases. So I'll have local bone, and I'll typically augment that with a synthetic. In the more common cases, in cases where I think we've got a high rate of good fusion, so for example, our ACDFs, our TLIFs, handling properties, I think become more relevant there, as well as the complication profile. So I'm concerned about heterotopic bone, I'm concerned about swelling, heterotopic bone in my TLIFs, I'm concerned about swelling in my ACDFs. So that's where I'm tending to use more likely a synthetic that's good handling properties. It'll stay within the space where I want it to stay, and that works well with either my structural allograft in the ACDF or with my interbody cage in the TLIF.
Quick question from our audience here. And by the way, I have to say, both you and Dr. LaMarca, just terrific presentations. Certainly a lot of surgeons like to use bone marrow aspirate or concentrate mixed with bone allograft. Would you take a few minutes and just talk about what sort of evidence is available for the efficacy for that, the bone marrow aspirate or concentrate with bone allograft?
Frank, you want to start with that one?
Yeah, sure. Obviously, in theory, the idea is quite good, and if you look at healthy bone and you're able to aspirate good amount of cells, and one's looking at mesenchymal stem cells particularly, it may have some benefit in an autologous intraoperative setting. The problem is most of our patients don't have that, aren't in that situation. They're usually, especially in the degenerative pathology. So it's very inconsistent, in terms of what you're going to get when applying these processes to your patient itself. So, and what we try to achieve, obviously, in surgery is a certain level of consistency, hopefully, because we know that what we put in is going to affect what we get out. So, I'm not a big fan personally, but I'll leave that to Sig, and he may have a little more information on what's in the literature.
Well, I'll just share with you that I'm going to quote primarily some preclinical data on this. Jill Helms from our lab here at UCSF did some terrific work using a rat tail model, suggesting that bone marrow from the rat actively contributed to the regenerate. So I do believe that bringing cells to the fusion is useful, and good evidence in preclinical work that the cells that are brought to the fusion site actually actively contribute to the regenerate. Furthermore, some work that Jim Triffid at Oxford, as well as Richard Refo is now at Southampton, they looked at mesenchymal cells that are derived from the bone marrow and showed that there is some age-dependent functional differences in mesenchymal cells that are derived from bone marrow. And certainly technique-wise, we know that if we're trying to aspirate more than about 2 cc's from one site, we tend to get more peripheral bone than mesenchymal cells. So I think there's good clinical evidence to suggest that bringing autogenous bone to the fusion, or autogenous cells to the fusion site, is useful. I've shared with you some evidence that suggests that allogeneic cells brought to the fusion site might not be as useful, but autogenous cells from the patient, I think, can be useful. And I do tend to mix autogenous cells with my synthetic. Now, where do we need more evidence? Well, I think very simply, looking at some of the synthetics with and without bone marrow aspirate, to actually have a study that suggests that there's an incremental value to the bone marrow aspirate is something that's notably absent right now.
Very interesting. Dr. Sage, any other questions?
Yeah, I do have more questions. So I think that there are a lot of surgeons that hear biologics and just kind of like zone out. And so, I mean, I personally am excited to geek out about this. But again, as an orthopedist, hardware is kind of like the fun part of it, right? So how do we get surgeons to think about their biologics and like really start reviewing the literature and getting into the nitty gritty of this? Because again, I do feel like it seems maybe sort of boring to some surgeons. And maybe that's just my perception.
Well, I hope our audience today is a subset of people who are actually interested in this, and knowing many of the people who are in our audience, I know that they are. And to that end, I think these are decisions that we make every single day. And I think with regard to our choice of biologics, we've got such an incredible range of products, and the level of evidence either supported or refuting these is really evolving on a monthly basis, if not even more rapidly than that. So I think this is an awfully important part for anybody who's certainly involved in a hospital formulary, trying to make informed decisions on what ought to be on your formulary, what ought to be available. That was a major driver for a lot of people's choice of bone grafts. And if you care about it, well, then be part of that decision-making if it's something that matters. And certainly just taking care of patients in a responsible way is having the best information we have. And I think as Frank introduced at the beginning, that, or perhaps you introduced, Catherine, that our choice of bone grafts may have is one of the modifiable variables that can have a major impact on our fusion rates, and perhaps even 60% of our fusion rate might be determined by what we choose for a bone graft material. So to that end, I think we've got an audience who's interested in this, who's not bored by it, and we recognize it's an important topic.
For sure. Dr. Sage, other questions?
I mean, I can keep going.
we have some time, so it's good.
Yeah, no, you're right. Because I agree that every month there's another article about a bone graft or biologic, specifically in spine. I feel like I see it all the time in journals now, more than I did earlier in my practice years. what's your advice to surgeons who are seeing all of this, like how to sort through it and know what to read and what to take into consideration when you're bringing products like this into your practice?
I think obviously, the more surgeons get into practice, the busier they get, and they have to pick and choose, where to spend their time, and even in education, unfortunately. The best answer is read as much as you can, but you're right. There's just so much you can read, and there's so many things that we want to cover. But to Sig's point earlier, I think, value is where we're all headed, and you sort of want a seat at the table in order to avoid that administrators or number crunchers are going to decide for you. And we also, we're interested in the numbers. It's not something we put aside, but we're primarily interested in the outcomes for our patients. So, if there's a certain area that has worked or that has been reported to be beneficial, I think educating oneself and to do it with what's peer reviewed is always much more reliable than what's not. So try to read. It's hard to say how to skim through it, because you're right, there are mountains of data. Wow. But I think if we look at what's most interested to us and we look at it in terms of how an administrator would look at it, that's I think is the best route to go. I don't know if you have anything to add.
And I'll just add to that, Catherine. I think certainly programs like this are useful. NASS has got some terrific overviews of bone graft materials at some of the symposia at NASS and at other society meetings. And I think in terms of looking at systematic reviews can really be a very nice way to get an overview of the literature. So the YOTA studies that were done York as well as University of Oregon specifically are a very nice overview of the randomized and prospective trials that reviewed the BMP data. Any of the prospective randomized control studies, the P15 studies are available in the literature. The DBM studies, I think Jim Kang's study is probably the highest level of evidence suggests that DBM is effective as a bone graft substitute. But looking at it is a quantifiable or it is a manageable amount of data to go through. If we look at the data through each category, I think the systematic reviews can be a very nice way to get an overview. And then from those systematic reviews from the reference list, you can get more information about any individual article you want to look at.
Yeah, I've been using the AAOS biologics dashboard too, and then also reading those NASS papers to, try and get the bird's eye view from some of the academies, societies.
I think the one one principle that you're pointing out is one size does not fit all. Depends on what case you're doing. You may end up, Sig, Frank, using different combinations for different patients depending on the indication. And on top of that, I think some of those longitudinal charts you guys put up were outstanding. They basically show that the science keeps moving forward. We keep trying new things, coming with new approaches, and getting deeper and deeper into what actually drives bone growth. And I think the kind of systematic research, Sig, you were doing, I saw Jeff Wang and some of the other folks were part of, you do keep bringing out comparative studies, which are so helpful. I guess I'd say, because I put out a publication, I'd say keep up with what Sig and Jeff Wang and Dr. Lamarca are writing, because you guys go to all the meetings, you stay on top of it, and that's a great way for anybody, any surgeon, to really be current. And again, not one size does not fit all, right, Sig?
That's a great point, Robert. That's a great point to wrap up on. Is one size does not fit all. Consider the patient, consider the host, consider the entire picture, and it's evolving. And let's all keep contributing to looking critically at the data.
Terrific. Dr. Lamarca, any final comments?
No, I think this has been. I've learned more than I've talked about at the meeting, to tell you the truth. So I appreciate it to be a part of it, and thank you very much.
Well, we're getting. I don't know. The attendees probably can't tell, but we on the panel are getting little emails and chats from members of the attendees congratulating us on having truly an even-handed science-based presentation. And while it's great to take the credit, really the credit goes to our sponsor, Kuros Bioscience, for organizing it in this way so that we really provide solid information to our audience. So with that, if we are at an appropriate time to do a close, is this about the right time, guys? Okay, I think so. Hang on, and just check one more thing, make sure we aren't missing anything. Okay, great. Okay, I think we are good for this evening. Thank you all very much. You were more than outstanding, and we're going to record this. It will be posted. I think this is the kind of a program that just should be available for anybody to look at anytime. So gentlemen, gentlewomen, thank you all so much. And Bonnie, if you could take us out, safe travels, everybody. Thank you to all of our speakers today for an outstanding program. And most importantly, thank you to all of our attendees for participating in this excellent masterclass. On behalf of our sponsor, Kuros Biosciences, and today's master faculty, be safe and stay well.